Assalamualaikum. Can just see whether the voices can be heard. Presenters.
Yes, Doctor.
All right. Is most of you in?
Yes. No, not all.
No.
Not all.
I think you guys can the presenter can start testing your slide whether you can be seen or not.
Can I see the slide?
Yes.
Right.
Try what slideshow.
Represent.
And
Slide.
the rest of the presenter just rest just try see whether your slide also can be seen.
Pakai slide.
Slide ada. Tapi dia tak jadi slide lagi.
Dah.
Dah jadi ni, dah present.
No.
Dia still dalam bentuk display yang window lagi.
Ya.
Aha.
Sekarang? Tak.
Tak pun.
Sama je.
Sama je.
Sekarang? Tak.
Okey.
Pun sama juga. Tak ada beza.
Dia tak jadi slideshow.
Dia tak jadi slideshow.
Slideshow mode.
Dia yang presenter mode
Ha.
Sekarang dah jadi slide.
Okay,
Sekarang
alright.
sekarang slide.
Okay. So I think the rest while waiting can try as well, see whether everything is okay.
Everyone
One
can
of the
hear me?
group leader has all the slide, right? Sometimes what happens is actually the presenter can't use the slide and then have to wait as well. Someone has all the slide, or each
This
presenter
one.
has the slide.
This one has
Yes.
compilation.
Yes,
Each
Faiz.
presenter have.
Okay, so we try hopefully, because sometimes one presenter has a problem with the slide and don't share.
Yeah.
Hopefully no problem. Okay, the rest ready join?
No, doktor.
Berapa orang tak join lagi?
Lagi 8 orang.
Orang tak join lagi? 8 ni. Okay, I think just we start.
Okay, bismillahirrahmanirrahim. So let's start our session today with recitation of Ummul Kitab Al-Fatihah. Okay, Assalamualaikum warahmatullahi taala wabarakatuh, and good evening. A bit to our supervisors and my fellow colleagues. So today we'll be presenting about a seminar under team neurology. So these are the These are the topics that will be highlighted for tonight's seminar. So the first topic is childhood epilepsy, and my name is Ahmad Faiz bin Abdul Rahman. So I will be presenting about childhood epilepsy. So first, epilepsy is a common neurological disorders that happens in 50 to 100 over 100,000 children and adolescents in Malaysia. Because it is common, we need to know this well in order to manage the condition. So first of all, we have to know the definition of seizure and epilepsy. So for seizure, it is defined as transient occurrence of signs and or symptoms resulting from abnormal excessive or synchronous neuronal activity in the brain. While epilepsy is defined as disorder of the brains characterized by an enduring predisposition to generate seizures and by the neurobiological, cognitive, psychological, and social consequences of this condition. So basically, these are the theoretical definition of seizure and epilepsy. So for clinical definition of epilepsy, it is defined as more than more than two unprovoked seizure that occurs in a time frame of longer than 24 hours. After that, seizure is then classified into various types since the early days, and these are the history of seizure classification. In the early days, seizure is divided into grand mal and petit mal seizure, whereas the grand mal is characterized by tonic-clonic seizure, and tonic is where the body becomes rigid, and clonic where there is uncontrolled jerking. After that, petit mal is very brief and announced lapses in consciousness, also known as absent seizure, and petit mal also takes the form of staring spells. After that, it evolved into partial and generalized seizure, where partial involve certain small area of the brain, and generalized is involve large area or the whole brain. And then partial seizure divided into two types, which are simple and complex seizure. And later on, it divided into, the classification was updated by International League Against Epilepsy in 2017. And this is the new classification. So basically, this classification is based on three key features, which are, the first one is where is the seizure, which classified into focal, generalized, or unknown onset. And the second one is whether it is aware or impaired awareness. And the third one is other features such as tonic cloning or myocloning and so on. So this is the classification. After that, we go to the childhood epilepsy syndrome. So what is childhood epilepsy syndrome? So based on the name itself, it is a cluster of specific signs and symptoms, and these include type of seizure the children have, the age of onset, clinical and developmental features, the EEG abnormalities, and also MRI findings. So this has to be distinguished from epileptic seizure, and the syndrome vary very greatly. Some are benign, where the children become seizure-free once they reach certain ages, and some are severe, and the seizure is very hard to control. And this is the summary of the childhood epilepsy syndrome in the form of table. So it's summarized into what are the epilepsy syndromes, the age of onset, the clinical symptoms, and the causes, also the prognosis and suggested treatment. So we have a lot of syndromes such as BRE, binaural epilepsy. It occurs in adolescent. We have benign focal neonatal convulsion that occurs in the neonates, and also we have any other type of the childhood epilepsy syndrome. So next we go how to diagnose this epilepsy or epilepsy syndrome. So based on ILA, they made a certain framework to establish the diagnosis of epilepsy and epilepsy syndrome. It is divided into certain multiple level. The first one, the level 1, is to establish whether it is an epileptic seizure or other things that known as seizure mimics, such as apnea, breath holding spells, vasovagal syncope, and so on. And also in this level also we can know what type of seizures that the children have. And next level, we proceed to establish the type of seizure based on evidence we have from clinical history and examination. And after that, we can establish the diagnosis of specific epilepsy by using supporting evidence such as supporting investigation such as EEG and also MRI. And the last level, we can determine the etiology and the coexistent comorbidities in the patient. So in the slide, we have listed down the etiology of the syndrome and or the epilepsy, such as genetic, structural, immune, infectious, and also unknown etiology, and also the comorbidities such as developmental delay, psychiatric symptoms, behavioral issue, academic difficulties, and many others. After that, we proceed with investigation that we can do in order to help in order to help us in making the diagnosis. So the most important investigation that we should do is the EEG, in electroencephalogram, and also neuroimaging such as MRI or CT scan of brain. From the EEG, we can help in classify the seizure into types, the epileptic syndrome, and also we can predict the recurrence of the seizure. So EEG it is a must to do after all effervescent unprovoked seizure in order to predict the recurrence. After that, for MRI or CT scan, so these are indicates if the patient have focal seizure or post-ictal deficit on neurologic exam if the patient status is not returning to baseline. And MRI is preferred over CT, and it should be performed in non-emergent setting. Other tests that we can do, such as routine investigations such as full blood count, renal profile if the child is unwell or having diarrhea, vomiting, or not alert. And also we can do lumbar puncture if infections cause is suspected, ECG to rule out long QT or other cardiac dysrhythmia, and other tests that can help in differentiate seizure from other seizure mimics. And next, we briefly will talk about status epilepticus. So the definition of status epilepticus is a condition resulting from either one, failure of the mechanism responsible for seizure termination, or the second, initiation of mechanism which leads to abnormally prolonged seizure. So status epilepticus will be divided into three types, which are the convulsive, where the seizures come with prominent motor symptoms. The second one is non-convulsive, where the seizures on EEG only, and also focal motor status epilepticus. So this status epilepticus is an emergency condition, and the treatment should be initiated um, when it is continuous seizure lasts more than 5 minutes, 2 or more discrete seizure lasting more than 5 minutes, between which there is incomplete recovery. And these are the algorithm that used in order to manage status epilepticus. And the management differs from time to time. And lastly, we will talk briefly about the treatment used in epilepsy. As we know, the pathophysiology behind the epilepsy is imbalance of neurotransmitter, whether excitatory or inhibitory. So there are many components that involve in the neuronal pathway. Thus, we can specifically target the component by using the certain modification or classes of anti-epileptics. So these are the summary of anti-epileptic drugs based on the classes of drugs, and also the mode of action and also the side effect. So there are calcium channel blockers such as etoxazumide that can block calcium channel, which have minimal side effect. And also we have carbonate anhydrase inhibitors such as acetazolamide, which can give rise to side effects such as Stevens-Johnson syndrome and renal calculi. And also we have drugs that can act on GABAergic neurons such as barbiturate, benzodiazepine, tiagabine, vigabatrin. We also have drugs that can act in synaptic vesicle 2A that will inhibit the presynaptic neurotransmitter release, such as levetiracetam and brivaracetam, that can have side effect of somnolence, asthenia, dizziness, and anger, irritability in children. We also have sodium channel blocker, such as carbamazepine, phenytoin, and lamotrigine, and drugs that can act on multiple targets, such as sodium valproate, topiramate, felbamate, and zonisamide. So basically, these are the summary of the drugs that we use in treating epilepsy. So that's all for me. These are my references.
Okay, I think we leave the question at the end of session.
Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So my name is Muhammad Naufal bin Amir Najib. I will proceed with the presentation about febrile seizure. So next. Okay, so febrile seizure is most common neurologic disorder of infant and also young children. It occurs 2 to 4% of children younger than 5 years of age. So by definition, what is febrile seizure? Febrile seizure is a seizure that associated with an elevated temperature, which is more than 38 degrees Celsius, and also it occurs older than 6 months old and younger than 6 years of age. And it occurs in the absence of CNS infection or inflammation like meningitis or encephalitis, and also in the absence of acute systemic metabolic abnormality like hypoglycemia. And also lastly, febrile seizure is a seizure that has no previous afebrile seizure. Okay, next. So next, febrile seizure will further classify into two categories, which is it is based on the clinical features. So the first one is the simple febrile seizure, and the second one is complex febrile seizure. So for simple febrile seizure, the duration is there is a mistake. Duration is less than 15 minutes, and as for complex febrile seizure, it is more than 15 minutes. So for simple febrile seizure, it is a generalized seizure. And also for complex febrile seizure, it is focal seizure. So the difference between generalized and focal seizure is generalized is the clinical features is generalized, like the tonic-clonic is all over the body. It is tonic-clonic, and for focal seizure, it is just involve one part of the body, like one limbs only. Okay. So next, the difference between simple and complex is the simple febrile seizure does not recur during the febrile episode, while complex febrile seizure is occur more than one during the febrile episode. And for complex febrile seizure, there will be a residual neurological deficit post-ictally, which is after the seizure. And for example, what happened during the complex febrile seizure is that there is without paralysis, which is a transient paralysis. Usually transient paralysis of the body, and it is usually just one side of the body. So this classification is very important in terms of prognosis, because in complex febrile seizure, it has higher risk of recurrent febrile seizure and also future non-febrile seizure. Okay, next. So about the pathophysiology, actually the exact underlying mechanism of febrile seizure is unknown or unclear, but there are some factors that may predispose or contribute to the occurrence of febrile seizure. So the first one is the high fever. So the high fever, which is the elevated temperature, will impact on the ion channel, just like what Faiz has present before, which is the occurrence of seizure is because of there is the disturbance in the balance between the excitation and inhibition neurotransmitter in the brain. So there will be increase in glutamate production and also reduction in GABA production. Thus increase the excitability and synchronization of neuronal activity in the brain. So therefore produce symptom of febrile seizure. So the next factor is infection, and the study shows that viral infection are commonly identified in association with febrile seizure as compared to bacterial infection, because viral infection like human herpes virus 6 and also influenza is associated with high fever, which is the first factor. It can cause the febrile seizure. So the next one is immunization. So in some studies that show that some vaccine like MMR and also DTWP have risk of febrile seizure, but the absolute risk is very low, which is about 1 in 14,000 dose. So in this factor, the genetic susceptibility also plays role. But in this issue, just like the previous presentation about immunization, in this issue we must look at the benefit and also risk in the immunization. So the last one is about the genetic susceptibility. So it also play a role and influence that can contribute to febrile seizure. So the first degree relative or family history has high risk of febrile seizure. So the gene that can you the gene has that responsible to in the febrile seizure is the gene that responsible in GABA receptor and also sodium channel lah. So when in this genetic sensitivity person, the gene is mutated, so it is predisposed to febrile seizure. So next. So in terms of diagnosis, I classify into history, physical examination, DDX, and also investigation. So in terms of history and physical examination, it is important to differentiate between is it febrile seizure or not. So the characteristic and also the duration of the seizure also we must take to differentiate between it is simple or complex febrile seizure. Just like I have said before, the duration of the simple is less than 50 minutes. For complex is more than 50 minutes. For the characteristic, there will be the simple seizure is generalized, and for the focal seizure is for complex is focal seizure, and there is also some residual neurological deficit in post-ictally in the complex febrile seizure. So we also must to ask about the underlying medical and neurological condition, because it also increase risk of serious infection or underlying structural abnormality. So we also have to ask about the personal or family history of seizure. So in terms of physical examination, it includes the general physical and also neurological examination. We must take the vital sign, the level of consciousness, the muscle tone, power, and the spontaneous movement. So in the children with febrile seizure, it is typically well, and the post-ictal drowsiness usually happen just 5 to 10 minutes only. So for the differential diagnosis, the first one is, so we must consider shaking chills, which is it is not seizure or epilepsy. It is just involuntary movement that occur during sleep, and sometimes it is confused with seizure. So next one is the CNS infection. CNS infection, just like meningitis or encephalitis. It is also the other differential diagnosis, because it has the same presentation, which is fever and seizure. So we also must look at the other features of the CNS infection, like altered consciousness, petechial rash, or also nuchal rigidity. And also in in meningitis and encephalitis, also CSF evaluation through the lumbar puncture is also important to diagnose meningitis and encephalitis. So the last one is the last differential diagnosis is genetic epilepsy with febrile seizure. So it is autosomal dominant syndrome, and its onset is usually early childhood and characterized by multiple febrile seizure. And it is unlike the febrile seizure, it continue beyond the age of 6 years old, and also associated with afebrile tonic-clonic seizure. So the last one is about the investigation. So the investigation is like food blood count, blood sugar, urinalysis, chest X-ray. The need of this investigation depend on the clinical assessment of the individual case. If, for example, if the patient has a history of vomiting, diarrhea, and also abnormal fluid intake. So actually, the investigation is not routinely recommended in child, uh, but for the lumbar puncture, uh, if it is performed, blood culture and also blood glucose, blood sugar must also be take for the comparison with the lumbar puncture. About the lumbar puncture, I will explain more at the end of this slide. So the last investigation is EEG, but it is not really indicated even in patient with multiple febrile seizure or complex febrile seizure. Okay, next. So about the complication. So the complication of febrile seizure is first, the first one is recurrent febrile seizure. The first complication is recurrent febrile seizure. It is usually happen in patient with family history of febrile seizure, and the age of the patient is less than 18 months old, and during the first episode the temperature is less than 40 degrees Celsius, and the duration between the onset of fever and the seizure is very brief. And usually less than 1 hour. So the next complication is subsequent epilepsy. It is happen when there is a neurodevelopmental abnormality, and also if the patient has the complex febrile seizure, it also can have as high risk subsequent epilepsy, and also for the patient with family history of epilepsy. Okay, next. Okay, in terms of management, majority of patients with febrile seizure ended spontaneously and rapidly return to normal baseline. So for the first one, about the hospital admission, not all children need hospital admission. There is some reason for the patient need to be admitted. First is to exclude the intracranial pathology, especially infection like meningitis and encephalitis. Second, fear of recurrent seizure. Third, to investigate and treat the cause of fever beside the meningitis and encephalitis. And also the last one is to allay the parental anxiety, especially for the patient which is live far from the hospital. So the second one is we have the fever should be treated with antipyretics like syrup or rectal paracetamol, and also the patient also have to avoid excessive clothing to control the fever. So next about the counseling, the parent also should be counseled about the nature of condition of their child. They have to be counseled about the relative risk of recurrence of febrile seizure or epilepsy, give emotional support, and also to educate them on how to handle their child with seizure actively, which is the next point I put there, is the first aid measures advice. The parent have to counsel about the first aid measures, which is in these first aid measures, there are some do's and don'ts. Which is like keep calm, don't panic, slowly turn their children over onto their sides, do not hold the person down, do not putting anything in their mouth. Next, for the parent with children which is high risk of recurrent febrile seizure should be supplied with rectal diazepam. So they should be advised on how to administer the rectal diazepam, and it is given after, usually if the seizure more than 5 minutes. Okay, next. Okay, so last one is about some question, which is lumbar puncture necessary for febrile seizure? Okay, so actually lumbar puncture is not necessary in most well appearing children who have returned to normal baseline after the seizure, but it must be done if there is suggestive of intracranial infection like meningitis or also encephalitis, like if the children have altered consciousness, nuchal rigidity, and also petechial rash. And also it is also have to be done if there is a persistent lethargy or not fully interactive. If the children is not fully interactive, so it must be done unless contraindicated. What is the contraindication? Which is coagulopathy, thrombocytopenia, raised intracranial pressure, and also cardiorespiratory sign. And also the lumbar puncture should be considered if the patient the age is less than 12 months. Hemophilia type B, the patient can have a mention with prior antibiotic therapy, because antibiotic treatment can mask the sign of meningitis. So I think that's all.
All right.
Thank you.
Very good. Next, continue with the next one.
So Bismillahirrahmanirrahim. Now I will be presenting about the meningitis and encephalitis. Next. So first we go to definition. So what is meningitis? Meningitis is the inflammation of the meninges, which are the three layers that cover the brain and also the spinal cord. Meanwhile, the encephalitis is the inflammation of the brain parenchyma, which can lead to the cerebral dysfunction. Most common causes for both meningitis and encephalitis is the viral infections. As you can see here, there are like enterovirus, Epstein-Barr virus, adenovirus, and mumps. Next, and then for the other cause of meningitis is bacterial meningitis. As you can see here, according to the age, there is likely bacterial infection. As you can see that E. coli and group B streptococcus is common in neonatal up to 3 months. And then above the 1 month, we can see that Neisseria meningitidis and also Streptococcus pneumonia are the most likely bacteria causes for meningitis. Next. And then this is pathophysiology for meningitis and encephalitis. For the meningitis, this is for the bacteria infections. First, the bacteria, usually bacteremia usually precede meningitis, or it can occur concomitantly. Then the bacteria gains entry to the CFS through the choroid plexus of lateral ventricle and meninges. And then the bacteria will multiply rapidly in the CFS, which this can lead to the release of inflammatory mediators and activated leukocytes together with endothelial damage. We can cause several edema, raise ICP, and also decrease cerebral blood flow. So in bacterial meningitis, mainly it caused due to the consequences of host immune response to the inflammatory cascade which initiated by bacteria component. And then for the encephalitis, there is two mechanisms which can cause the destruction of the brain tissue. The first is direct infection and destruction of the neural tissue by actively multiplying viruses. And then for the second one is encephalitis can occur as a secondary immunologic complication of certain virus infection. In this condition, the immune system will attack one or more CNS antigen that resembles protein of the infection virus. Next. Next, we go to the clinical features. Regardless of the etiology, most patients with CNS infection might have similar clinical manifestation. As list here, you can see that the sign, also the symptom of the meningitis and also the encephalitis. For the infant or younger children, the clinical manifestation are non-specific, like fever, poor feeding, vomiting, lethargy, loss of consciousness. And then what we need to note is that the meningeal signs, which is specific for meningitis, like photophobia, neck stiffness, positive Buzinski and Koenig signs. For the encephalitis, the most common presentation of patient with encephalitis is fever, loss of consciousness, and seizure. The purple star that I put there, and then it can also presented with the sign and symptom of brain dysfunctions like confusion or bizarre behavior. And then for the initially the clinical manifestation of encephalitis is difficult to distinguish from the meningitis, as encephalitis can also, the patient with encephalitis can also have meningeal signs like neck stiffness, photophobia, and positive Buzinski and Koenig sign. And also I want to highlight the purple rash, like you can see in the picture below at the right corner. This is a purple rash which present in febrile children. So if there is purple rash in febrile children and also sign or symptom of meningitis, we can assume that this infection is caused by meningococcal disease, which is caused by the Neisseria meningitidis. Next. So this is the clinical feature for Buzinski sign and Koenig sign. For Buzinski signs, there is when we try to flex the neck of the patient, there will be flexion of the knee and the hips. And for the Koenig sign, for positive result is when we with the patient lying supine with hips and knee flex, when we try to extend the knee, the patient might feel pain, and also there might be some resistance on the extensions. Okay, next. So this is a diagnosis and investigation as I have listed here. What I want to highlight is that the diagnostic investigation is the lumbar puncture for CFS, unless it's contraindicated, like our friend has mentioned before. So the lumbar puncture is important in order to get the CFS for analysis. By doing this, we can actually likely to get the causes of the infections. Other than that, we can also do PCR of blood and also CFS for possible organism. If we suspect the meningitis is caused by TB, we can do chest X-ray, Mantoux test, interferon gamma release assay, gastric aspirate and sputum for microscopy and culture. Also, we need to consider to do CT, MRI, brain scan, and EEG, which more likely we need to do in encephalitis in order to confirm the diagnosis. However, it does not likely to confirm the likely causes of infections. Next. This is the finding of CFS analysis from lumbar puncture, which provide overview of expected CFS abnormality according to the etiology. First, we can see that meningitis is caused by bacteria. The appearance of the CFS can be tubic, and of course, the white cell count will be increased, and the predominance cell is polymorph, which can be neutrophils, and then it will be increased in protein and moderate loss in glucose. And then for the viral infections, for meningitis, the CFS finding is almost the same with the encephalitis. As you can see, the appearance is clear. The white cell count will slightly increase, and the predominant cell is lymphocyte. And the protein can be normal or increased, and the glucose can be normal or reduced. And for the tuberculosis, there is various appearance of the CFS, like to be clear or viscous. And for the white cell count, they will be slightly increased. And then the predominant cell is lymphocyte. And then there will be extreme elevation of protein and also extreme reduction of the glucose. So if this, we can see this, we will likely to say that the causative agent is tuberculosis. Some of the viral may not recovered by CFS analysis, so we can do PCR for the CFS to look for viral genome. Okay, next. Next, we will go to the complications of the meningitis and also encephalitis. So as you can see here, the first complication for meningitis is hearing impairment, which is due to the inflammatory damage to the cochlear hair cell that may lead to deafness. The second one is hydrocephalus. It can be communicating, which is caused by the impaired resorption of CFS, or it can present with non-communicating hydrocephalus, which is due to the cerebral blockage of the aqueduct or ventricular outlets. Patients that have hydrocephalus may require ventricular shunt. And then the third one is local vasculitis, which may lead to cranial nerve palsy or cerebral palsy. The fourth one is cerebral abscess, which can be confirmed on cranial CT or MRI scan, which we can see them as a enhancement of ring lesion on the brain. And then for the fifth one is the local cerebral infarction, which may result in focal or multifocal seizure. The last for the meningitis is subdural effusion, which are particularly associated with H. influenza and pneumococcal meningitis. And then for the qualification of encephalitis, as I listed here, it can be paralysis. And the second one is spasticity and cognitive impairment, ataxia or recurrent seizure. So both of the complication of meningitis and encephalitis can also cause seizure. And then next one. Next is they show the brain CT scan, the complication of the meningitis. As the left one, we can see there is a brain infarctions. And then in the middle one, we can see there is ring lesion on the left side, which shows that there is cerebral abscess. And then the last one is the bilateral subdural effusion. Okay, next. So for the last one is the evidence-based medicine about the topic of corticosteroid in meningitis and encephalitis. So as I showed here, there's evidence here about effectiveness of CAS for patients with acute bacterial meningitis. So it is proven that the use of steroid can decrease the sequelae of bacterial meningitis. As you can see that I do the red box, we can see that there is high evidence of corticosteroid that it can reduce the complications such as severe hearing loss, any hearing loss, and short-term neurological sequelae. So, why do we need to administer corticosteroid beside antibiotics? So, by giving antibiotic, it will kill bacteria in CFS effectively, sterilize the meningeal infection. But however, it can release toxic substance after the cell lysis. We can precipitate the cytokine mediated induced cascade, which can give additional neurologic injury with worsening CNS signs and symptoms. So by giving the corticosteroid, it can prevent and limits the production of inflammatory mediator. Thus, it may benefit to the patient with bacterial meningitis. So it is best to administer corticosteroid if given before or with the first antibiotic dose to get the best achievements. For example, we can give dexamethasone to 0.15 milligram per kg 6 hourly for 4 days. You can look for the management of this in the PITS protocol. And then, okay, I think that's all for my part. We proceed to the next presenter.
Okay, we'll take a short 5 minutes break, and after this, we open up Q&A for the first three presentation when we come back. So just think what question you want to ask. Just have a 5 minutes break.
Okay, Doctor.
Okay, do you have a question for presenters? Huh? The first three topics. Huh? Anyone? No? Huh?
Sorry, I have a question, but I don't know if you can hear me.
Tengah azan pula Tunggu azan lah. Apa lagi? Tengah azan. Maybe you want to type your question ni kalau tak panjang while waiting.
Okay. Can I ask a question?
Okay, alright. Okay.
I want to ask if how effective the BCG in preventing the tuberculous meningitis in children, and for how long does this protection last?
Who wants to answer? First presenter. First, third presenter. Any idea?
Actually, I don't know the accurate answer about the effectiveness of BCG, but as presented before by the vaccine, if most of the people will not get the vaccine, it will not, the effectiveness will be low, because if many people get vaccine, it will actually give a what we call it, community. I don't know what is the term. So maybe this. So I don't know, doctor, how
Anyone?
effectiveness.
Anyone else? All right. Okay. Actually, again, the rationale why not all countries in the world give a TB vaccine. Actually, the primary or the evidence actually is not for the protection of TB infection. That's why we still have pulmonary TB. It's not it's not actually really protection for pulmonary TB. Because that's why we still have a high PTB in Malaysia, in the rest of the world. Actually, primarily it is found that actually there's some protection for TB meningitis in children. So how long? Some evidence say up to 10 years, but most evidence say only up to 6 to 7 years. So that's why now in Malaysia, I mean, I'm sure that in the past that at least 5 years ago, when standard 1 children it's been reviewed in clinic, they have no TB scar, then there will be vaccination for TB. But actually, it's not a current practice, because if there is evidence of TB vaccine has been given, even without the scar, actually very little support to give TB vaccine again when they are in standard 1. So it's not been practiced anymore. So, but in situation where the household has TB contact, even children or infant who has TB vaccine, they still have a risk of having TB meningitis. It's not like 100% protection. Even the protection is actually said just about 60 to 70% for TB meningitis. So don't. We must be very clear. The reason why we give BCG vaccine is not for prevention of pulmonary TB, but actually to reduce the risk of TB meningitis, because TB meningitis come with a high morbidity and mortality. That's the reason why. So if you have some people who refuse to get a BCG vaccine with the reason why it didn't protect anyway, so you should be able to give them a picture. Actually, there's already review paper regarding the role of TB. What you can just write BCG. You can just Google and BCG vaccine for prevention of TB meningitis. PubMed. PubMed means actually there's actually quite whole literature including review there, so you can quickly do that after this. Okay, quite clear. Any quite clear? Is it clear or you not sure?
Yes, doctor.
Okay, all right. Any other question?
I have one question regarding the febrile seizure. One of the complication mentioned by the presenter, it can cause neuro developmental macam deficit lah kan? Does it mean it can cause like brain damage that eventually cause intellectual or learning disability?
Okay, the presenter, any response?
Actually, for the slide, there is some misunderstanding. Actually, the complication is not neurodevelopmental abnormality, but can Faiz back to the slide? Actually, the complication is the one, the word with number lah, the recurrent febrile seizure and also subsequent epilepsy. And this complication is, the risk is high if there is the following description lah. For the neurodevelopmental abnormality, if there is a neurodevelopmental abnormality, there will be a high risk for subsequent epilepsy. I hope that is the answer.
What is the risk of what is the percentage? Do you know percentage of risk a child with a febrile fit to develop into epilepsy? What's the risk? And so-called normal or common febrile seizures.
I refer to protocol. It said 2 to 7% will develop into subsequent epilepsy. 2 to 7%.
Actually, quite low. Actually, the common numbers is actually less than 0.1% for simple febrile fit. So actually, there are some figures that you can, if you can recall, is actually the risk of developing seizure within the first 24 hours of having febrile fit, no, you got fever now, you got fit now, the risk of developing another seizure is about 50%. Okay, and they have 33% risk of developing febrile seizure in the future, with less than 0.1% of ever developing epilepsy in case of simple febrile fever. So it's very, 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 very low. So those who had epilepsy is primarily if they have complex and family history. Okay, any other question? If not, we continue with the fourth presenter. Hold on, I got a call from hospital. Hello. Yeah, yeah. Okay. Okay, yeah. Okay. Okay, all right. Okay. Okay, all right. Okay, you're right. Okay. Okay. All right. Okay, I think just boleh I think just advise dia, I think kalau dia happy balik rumah je lah. Yeah. I think kalau midnight Saturday morning tak okay lagi, I think come back, and if they come back after midnight, then definitely aim for regular nap lah. So you just give option to the parents lah if they're happy, because I must say nothing most likely will be okay. Sebab the PrEP will kick off, the PrEP effect will kick off lah after malam ni. But after midnight, observe lah, after midnight tu tak okay, they're not happy, come back lah. But this time kalau masuk admit, and then you admit as acute bronchiolitis with bronchospasm. Kalau dia masuk malam nanti you jaga lagi kan, you still on malam ni. Alright, bronchiolitis with bronchospasm, and then keep regular pump and macam biasa. Right? So just a simple blood workup, mungkin tak payah antibiotik dulu kot. Kalau dia tak ada fever pun, tapi kalau dapat, kata dia masuk lah 9, and then ABC, kalau tak dapat tak payah, tapi at least dapat blood. Right? So nap regular, and then tak payah antibiotik dulu. Okay. Nanti kalau ada problem, just review balik kat my clinic lah. Kalau dia tak happy. Datang sini je lah. I review. Okay, alright. Okay guys, sorry. Continue.
Right. Bismillahirrahmanirrahim. Let me continue with the next neurological problem in children, which is most commonly caused motor impairment in child. So it is a cerebral palsy. Okay, next. Okay, by definition, cerebral means problem having to do with the brain, whereas for palsy, it is there is a weakness or problems in using the muscle. So as a whole, cerebral palsy is a diagnostic term used to describe a group of permanent disorder of movement and or posture, and this is due to non-progressive abnormality in the developing brain. So there are a few keywords here in the definition that we have to really take a look. So the first one, this cerebral palsy is a permanent disorder which is persistent. Next, it is a disorder of the posture and movement. And the third key point is the lesion is non-progressive lesion. So cerebral palsy actually is a subgroup of static encephalopathy, whereby static here means that the brain lesion itself is static. There will be no regression in the cerebral palsy. So actually in cerebral palsy, we can see the patient will have developmental delay. For example, actually at the age of 15 months, the patient should supposed to walk. However, due to developmental delay, there will be this patient not achieve the milestone. However, cerebral palsy have no developmental regressions, meaning to say that there will be no worsening of problem. Next. So this is the pathophysiology for cerebral palsy. There are few risk factors for development of cerebral palsy. We can classify it into antenatal period, perinatal period, as well as postnatal period. So for antenatal period, basically it associated with prematurity and low birth weight. So preterm labor have actually high susceptibility to cause periventricular leukomalacia, which I will explain later, and also intraventricular hemorrhage. So other than prematurity, intrauterine infection also can cause cerebral palsy. For example, the chorioamnionitis, and as well as the TORCH, T-O-R-C-H, the congenital infection. Other than that, multiple gestation also could one of the risk factor for the development of cerebral palsy. All right. Okay, for the perinatal risk factor, it is the birth asphyxia can also lead to cerebral palsy, as well as coronary arrest, which is there will be high bilirubin in the blood. The bilirubin type is indirect bilirubin. So indirect bilirubin, as we all know, it is a lipid soluble, so it can cross the blood-brain barrier and lead to coronary arrest. And for postnatal, like we have see before about the meningitis and encephalitis, it is one of the risk factor for development of cerebral palsy. Okay, next. See, okay. So as I already said just now, prematurity have highly susceptible to get periventricular leukomalacia. So periventricular means that there is a lesion at the ventricular area, which is the white matter, at the side of the white matter. So basically, as you can see in the diagram at the rightmost side, the periventricular area have the watershed zone, which is vulnerable when there is a hypoxic ischemic condition. So at this area, when there is a hypoxic or ischemic, they will cause brain cell die and multicystic area will be formed. And then, okay. So basically, this is a brief pathophysiology regarding periventricular leukomalacia. Okay, next. So for classification of cerebral palsy, we can actually classify it based on these three criteria, which is the first one is based on neurological features. In cerebral palsy, actually we have, for example, like spastic cerebral palsy, dyskinetic cerebral palsy, ataxic, as well as mixed or other or mixed cerebral palsy. So for spastic cerebral palsy, it actually involves the pyramidal tract, which is like a cortex or subcortex, brainstem or spinal cord. And in the pyramidal tract, there will be a GABA impaired, so there will be high excitatory, so that lead to features of spastic. So as it involves the pyramidal tract, they will have a sign of upper motor neuron sign like spastic, hyperreflexia, clonus, as well as Babinski. So spastic cerebral palsy is the most common in cerebral palsy as compared to dyskinetic, ataxic, and other. So in spastic as well, it is further classified into based on the body affected, like hemiplegia, which is half of the body, quadriplegia, all 4 limbs, and diplegia, more significant on the lower limb, which is the legs. Okay, right. That's first for the spastic. Next is for dyskinetic. As for spastic, it involves the pyramidal tract. For dyskinetic, it involves the basal ganglia or extrapyramidal tract. So as we all have already learned that basal ganglia actually the function is to initiate and prevent movement to. Okay. However, in cerebral palsy, there will be no prevention by this basal ganglia, so it will lead to involuntary movement. All right. In this kinetic, actually, there will be further criteria like further features like dystonia, chorioactitoid, and these are very important to notice the features so that we can easily diagnose. And and the third one is the ataxic. Ataxic mainly the lesion is in the cerebellum, so it lead to poor balance and coordination. All right, moving on to the third criteria, because for the second I already mentioned about for the classification for spastic, which is spastic hemiplegia, spastic diplegia, spastic quadriplegia. Okay, for the third, it is also important for us to know the gross motor function classification system, GMFCS, because by this we can know the severity of the cerebral palsy. So for the level 1, they will the child can walk without limitation. However, in level 2, the child still can work, but with a few limitations, like the child cannot climb. Okay, for the level 3, the child need to use handheld mobility device. And for level 4, they will be the child may use powered mobility. And level 5 is backbound. But actually, basically, it is a backbound that need to be transported in manual wheelchair by other person. Okay, this is briefly for the classification of cerebral palsy. Next. Here are more in detail according to each type of cerebral palsy. Okay, let us look for the left picture. Okay, basically, here there will it is classified cerebral palsy into spastic, which is the first one is spastic, as well as hemiplegic, which is spastic and half of the body affected. So the most common etiology in spastic hemiplegic cerebral palsy is due to infarct or ischemic due to perinatal middle cerebral artery. So
okay,
for the
in this section, you just need to know briefly the classification. You don't have to. We didn't really ask you in detail. You should know some of the classification. Should be able to come out with in your short case. Should be able to come out at what are the possible. You choose whichever that you feels that the appropriate classification. You don't have to know this in detail. It's too much for you. I think you can move on. The first slide is quite. The previous slide is quite helpful already. And you don't have to go in detail. This is a bit too much for you. This one for neurologists. All right. Okay.
All right.
Move on to next.
Yeah. Move on. Okay. This is a few clinical features in cerebral palsy. Okay. For the symptom, the mother might complain that her child have feeding difficulty, such as oromotor incoordination, slow feeding, gagging, and vomiting. Okay, this symptom might be due to pseudobulbar palsy, which is a lesion in the upper motor neuron of cranial nerve, especially in cranial nerve 5 that involve in muscle of mastication. Okay. Other than that, okay. For the signs, there will be a delay motor milestone, abnormal limb or trunk posture and tone, abnormal gaits once the walking is achieved, asymmetric hand function before 12 months age, meaning to say that the child will have hand preference before the age of 12 months. Because usually hand preference occur after 1 year, 1 year old. Okay, other sign could be there will be a persistence of primitive reflexes. Okay, next. Okay, this is among the associated problem that occur in cerebral palsy. Okay, as what have I told you just now, it is more, we can see that it is most likely to be a motor lesion, right? Motor problem like in the walking. Okay. However, actually, the cerebral palsy, as the cerebral suggests, there will be lesion as well in the brain. So the associated problem include seizure or epilepsy that commonly associated in quadriplegic, spastic quadriplegic cerebral palsy, and also for learning difficulty. It is more commonly in spastic quadriplegia. Other than that, there will be behavioral challenges, visual impairment, sensory neural deafness, feeding problem, dental caries, speech, as well as scoliosis, hip dislocation due to spasticity, constipation, and urinary incontinence. So, okay, for the first picture, you can see the infant. This infant had spastic bilateral or quadriplegia. You can see the for the upper limb, it show pronated forearm and fisted hands, as well as for the lower limb, it show that the scissoring of the leg due to excessive adduction of the hips. The second picture showing regarding diplegic, spastic diplegic cerebral palsy. So we can see the upper trunk, the trunk is flat, and there will be a scissor gait as well in the lower limb. And the third picture basically just info regarding the developmental milestone and the abnormality in cerebral palsy. And the fourth picture showing the hemiplegic, spastic hemiplegic cerebral palsy. Next slide. So, okay, for diagnosis, in cerebral palsy, it's not easy to detect in early life because we have to go through and look for the development of the child itself. So we need to get thorough history and physical examination to exclude the progressive disorder such as degenerative disease, metabolic disorder, spinal cord tumor, and muscular dystrophy. So we can suspected cerebral palsy by looking for the risk and etiology affected the brain using maybe using a brain MRI. We can, if there is a delay in reaching the normal development milestone or persistent remain of primitive reflex. And there will be also less facial expression and abnormal gait or posture. So this is a differential diagnosis for cerebral palsy. You can read it. Okay, for the investigation, basically we do the investigation to rule out either the differential diagnosis as well. For example, we do thyroid function test to rule out any congenital hypothyroidism, imaging study, but like brain MRI to look for other lesion or to look for any multicystic in the PVL, which is periventricular leukomalacia. We do EEG if there is a fitting condition, chromosomal karyotype test to rule out any chromosomal anomalies, and the list go on based on the case. and the scenario. Okay, next slide. Okay. For cerebral palsy, the long-term management, we have to do it in a multidisciplinary team approach because it involves lots of system. So for the first one, we have to support the body system because we know that cerebral palsy most affect the musculoskeletal system. Thus, the child have to undergo physiotherapy, give medication to reduce spasticity and do surgery if indicated. Nervous system to treat any seizure or abnormal movement, respiratory system to do chest physiotherapy, suction vaccine, early vaccine. And for GIT system, hearing and vision, because there will be also a hearing vision impairment in certain cerebral palsy. And palliative care in the case of GMFCS5, because we know that this child is a bedbound. So we have to try to improve the quality of life of this patient. And next about is regarding genetic or parental counseling. And lastly, long-term follow-up to look for to monitor the compliance to medication as well as monitor the activity daily living of the child. Next. So for the one of the medication used in cerebral palsy is botulinum or Botox. So botulinum toxin type A. So basically, botulinum toxin, the mechanism of action by block acetylcholine release. So when the acetylcholine is blocked from release, there will be decreased spasticity of the muscle. So that will reduce the spasticity because one of the features in cerebral palsy is spasticity. So actually, there is a strong evidence for reduction in spasticity in plantar flexure of the ankle after injection of botulinum toxin, and moderate evidence for small improvement, and weak evidence for improvement in gross motor function. So one of the major side effect in botulinum toxin is actually muscle atrophy and fibrosis, because we block the acetylcholine release, so the muscle will become less used and become atrophy and fibrotic. So here is we have to weigh the harms and benefit to use botulinum toxin in a child with cerebral palsy. Okay, I think that's all.
Okay, all right, we continue next one before Q&A.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can everyone hear me?
Can.
Yes.
Right. So Bismillahirrahmanirrahim. Inshallah, I'll be presenting about the last part of this seminar, and the topic is muscular dystrophy. So next, and my name is Abdulaziz bin Saifullah, and I'll be presenting about this this disorder. Next. But first, we must define first what's the meaning of muscular dystrophy, taken from Kumas. Before this, disorders of skeletal and sometimes cardiac muscle have complex clinical and neurogenetic classifications. Hence, the main point here is that it is a progressive disease, and also it affecting the skeletal muscles, sometimes cardiac muscles. And the term dystrophy means abnormal growth. It means there is a malnutrition of the muscles, impairment of the muscle growth. Next. The criteria, muscular dystrophy is distinguished from all other disorders of the neuromuscular diseases by 4 obligatory criteria. So the primary morbidity is exclude other neurogenic neuromuscular disease. Genetic disease the cause is progressive. So any diseases of muscles that is non-progressive, like it's acute in onset or always progressive. Once the onset or diagnosis being made to the patient, hence the progressions of the disease will continue, and the stage in the disease. Just to understand that the muscular dystrophy is a group of unrelated diseases transmitted by different genetic traits, each differing in its clinical causes and experiences. So it's basically any mutation in some genes may lead to spectrum of clinical phenotypes. It's ranging different in each of onset, severity, and presence of comorbidities. Next. These are common muscular dystrophy, Duchenne muscular dystrophy, Becker muscular dystrophy, which is mild versions of DMD. You can read all those, but today we will be focusing on the blue-colored muscular dystrophy, which is Duchenne muscular dystrophy. Next. Basically, I go straight to the pathophysiology of Duchenne muscular dystrophy, just to share about a little bit. Duchenne dystrophy is X-recessive, X-linked recessive gene mutations that affecting XP21 locus, and it clinically manifested by progressive weaknesses, intellectual impairments, pseudo hypertrophy of the muscles. So the pathophysiology is that the absence of the gene product dystrophin, basically the locus have quite 79 exon, and there's a few deletions of certain point within the locus, causing dystrophin. And this dystrophin is very important and essential for cell membrane stability. Hence, when there's no dystrophin produced within the cell membranes, causing the cell membranes to be unstable and susceptible to injury, and then can cause the cell death, and then it will lead to muscle fibrosis. And when the cell death occurs, the creatine kinase and serum creatine kinase will detect when that thing occurs. Next. So the clinical features, the sign and symptoms, because usually is DMD, Duchenne muscular dystrophy, rarely symptomatic at birth or infancy. It can occur when it may achieve normal walking, but the early signs can be realized or can be seen by the parents by difficulty in running. The goer signs when the children needs assisted with hands to stand up from lying down or from sitting. Initial proximal limb weaknesses, calf pseudohypertrophy due to the fibrosis of the muscles and the infiltration of the increased fatty hence the calf is not hypertrophed with the muscle fibers, but with other tissues other than muscle tissues. And gait due to proximal limb weaknesses, and also there's a muscle weaknesses. So these symptoms, basically the sign and symptoms is referring to the weaknesses of the muscles. So investigation, as I said before, that the death of the muscles increased creatine kinase more than 10,000 international unit per liter. It can range between 10,000 or 36,000, which is the normal level is around less than 160. And then the diagnostic investigation that can be done is using histochemical staining, and also mutation in dystrophin from DNA test, and also Western blot. basically do DNA testing to look for any mutation in the dystrophin gene. Next. So the complications and the long-term care, complications and the long-term effects of this disease, this muscle atrophy, require and significant at certain point at terminal stage of the disease, the patient may have paralysis. The common age of paralysis or dependent to other persons is between 10 to 14. However, the progressive or the progressions in the development of the treatment increase the age. However, the progressive it does not cure, it's only treat or slow the progressions of the disease. And next is respiratory failure due to weak diaphragm. Basically the same when there's a impairment of the muscles, hence it can lead to respiratory failure, which becomes the cause for patients with Duchenne muscular dystrophy, the cardiomegaly, cardiac arrhythmia. Because in patients with DMD, sometimes in certain severity, it will affect the cardiac muscles, and because this dystrophin is very important for and also the cardiac muscles and muscle cells membrane. Okay, next. Oh, by the way, the complication, one of the complications is also contracture and also intellectual impairment. But the physiology is that the pathology is still within the spectrum of due to the mutation in the gene causing the manifestation with and also one of the effects of the muscle weaknesses is also the scoliosis and paralysis. Treatment: there's no medical cure for this disease at this time, but also to alter or to adjust the genes to fill up the gap within the gene to produce a functional dystrophin for the patient. However, it's only to treat, not to cure the Duchenne muscular dystrophy. The glucocorticoid have been shown to decline muscle strength. It means the prescription of prednisone or glucocorticoids can slow slow the progressions of the rate of progressions of the disease. Most of the time, the treatment is focusing on the complications such as complications like cardiac, long-term visit to cardiologists or to pediatricians to look for any signs of cardiomyopathy, and also try to look for any signs of complications from the patients who diagnosed with DMD. And I think this is the last slide. And that's all from me. This is my reference.
Okay, all right. Very good, everyone. Okay, any question in relation to the last two presenter?
I have a question. I want to ask if a cerebral palsy and head circumference has any correlation, or if a baby with a cerebral palsy always come with microcephaly.
Actually, not specific. If you identify during follow-up, you identify either macro or microcephaly, so means that the head circumference is more than 95th or less than 3rd percentile, then you're gonna have to again what do you call this? Get the history right. So then get the history from antenatal, prenatal, and postnatal, which can explain the reason of the microcephaly, right? Or macrocephaly. So other condition, metabolic condition, can also cause macro and microcephaly. Right, you got glycogen storage disorder, you have macrocephaly. Microcephaly can occur in torches. Okay, condition example, not primarily cerebral palsy. So you see, it's a correlation. There is association, but not good correlation. So because microcephaly can occur in many other conditions. So if you have a patient come with micro or macrocephaly, then again history and physical examination is most important. You may be able to elicit some hypertonicity in case of example cerebral palsy, example. So, but otherwise, again, as your friends have discussed, it's difficult initially. You have to get follow up. So you probably after 6 months to 12 months, you'll be more clear, and after 12 months, it'll be a bit more, even clearer how to diagnose. So sometimes it's difficult to diagnose people with cerebral palsy when they are during first 3 months of life. Okay. Other question? Okay, all right. No question. Then we should have. Okay, everybody should it's quite good presentation, not too lengthy. The group leader, please email me the slides. So for safekeeping. Okay. All right. So we end up with tasbih kifarah. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Thank you.
Doktor.
Thank you, Doctor.
Thank you, Doctor.
Yes, juga.